I'm Manudeep Kalra and I'm from Mass General Hospital, and I'll be speaking on pregnant patients' risks and strategies for CT. These are my financial disclosures. The objective of this talk is to understand risks of CT radiation exposure in pregnancy and steps to reduce or optimize radiation dose from CT, which may include appropriate indications, reducing scan length, optimizing scan parameters, and use of shields. Ionizing radiation effects in pregnancy. Well, the ionizing radiation to the fetus or the conceptus can occur either from direct exposure, which is when the fetus or the embryo lie in the direct path of the X-rays from the CT, or from the scattered X-ray exposure, where the fetus may come to have the radiation dose from scattering happening from a CT that is done from outside of the area where the fetus is present. For example, when we are doing chest CT and the fetus in the abdomen gets exposed. The effects on the fetus can result either from direct cellular damage when the molecule, predominantly the DNA molecule, lies in the path of the X-rays, or it can occur as an indirect effect where a free radical that is formed because of the radiation exposure interacts and damages the DNA and leads to an effect. So the effects of radiation dose in an embryo can be of three types. It can lead to three types of injuries, basically: mutagenesis, teratogenesis, and carcinogenesis. Radiation mutagenesis includes germ-line genes alterations and mutations which can affect the future generations, not really the one who got exposed. For example, the pregnant mother is not going to get these effects. It would be the offspring of the embryo or the conceptus that will manifest with these effects, and generally most of these genetic effects are actually filtered out or are repaired, so that in human beings the radiation mutagenesis has never been demonstrated. Even in the Hiroshima-Nagasaki explosion, people who were followed for many years, we could not demonstrate any genetic effects. These effects have been predominantly noted in small plants and animal studies at very high levels of radiation dose. So, talking about the teratogenesis, even without radiation exposure, there is a prevalence of congenital malformations that happens for the embryo or the conceptus. It's said that it's about 45 per 1,000 live births that there will be congenital malformations, of which almost 2/3 of them are major malformations which can involve the cardiovascular or central nervous systems. And then roughly 1/3 of those are actually minor malformations which can affect the fetus even without radiation exposure. So this is very important to know when you are counseling a patient who has received radiation dose, because there is a background risk of having congenital malformation even without radiation exposure. So this is the chart which shows basically the age of the embryo and the fetus at different phases of the pregnancy. In the first 2 weeks, typically any exposure leads to failure of implantation of the zygote in the uterus and leads to spontaneous abortion, and therefore there will be prenatal death and no congenital malformations occur. Between 2 to 8 weeks is the most sensitive period for development of congenital malformations or teratogenesis, and after the 8th week predominantly there are very minor, mostly functional impairments or very minor morphological. So this table actually shows the radiation exposure at different weeks of gestation. In the first week, as we saw in the previous slide, that most of the times there is prenatal death, and that prenatal death typically requires about 100 milligray to happen, right? A dose that's less than 100 milligray, and that figure is also somewhat controversial. Some people say it's 200, and some other organizations point it to be 100. Well, at that exposure there will be perinatal death. Between 2 to 8 weeks, the most important side effect is intrauterine growth retardation and also mental retardation, and typically that requires a dose over 200 milligray. And as you can see from this table, beyond 8 weeks or from the effect basically is limited to either microcephaly or small organs or intrauterine growth retardation, and the doses that are needed are significantly higher than that needed during the first week. On the other hand, if you look at the CT dose, this table actually demonstrates the CT doses to the fetus or the embryo, and you can see that for the head CT in the mother, the fetal exposure is less than 1/100th of a milligray to the fetus. So extremely small dose compared to what would be needed to cause a teratogenic effect. For chest CT, again, the doses are less than 0.1 to 0.2 milligray when the mother has a CT, either a routine CT or a pulmonary embolism CT or CT for evaluation of coronary arteries. For abdominal CT, the doses are considerably higher. For example, for a routine abdomen pelvis CT, the doses can be about an average of 25. Now, that's one of the higher doses with abdominal CT, and abdominal aorta CTA can have even higher doses, predominantly because it's a multi-phase study. Now, it's important to know that these doses are without much dose modulation or dose adjustment. If we apply appropriate scanning parameters and appropriate techniques to optimize the dose, those doses can be even lower. So the radiation carcinogenesis to the conceptus is probably the single most important risk to the conceptus following in utero radiation exposure. Certainly there are studies that have shown that background leukemia rate in the conceptus increases from 3.6 per 10,000 to 5 per 10,000 even after exposure to radiation dose as small as 1 to 2 milligray. And as we saw from the previous slide, a CT of the abdomen can be associated with much higher doses than 1 to 2 milligrays. This table, actually taken from the Radiology Clinics of North America from an article from Cynthia McCullough, basically illustrates that how much is the background risk of congenital malformations in cancer with and without radiation dose. So in the first row, as you can see, even without any additional radiation exposure to the conceptus, there is about 4% chance that the child will have some kind of congenital malformation and about 0.07% chance that the patient or the conceptus is going to develop cancer, a childhood malignancy, right? With increasing exposure, as you can see from here, you can see that there is increasing but very slight increase in malformation, almost 0.2%. But what's interesting to note is that the childhood cancer would actually increase by as much as 1% when the radiation dose goes on increasing from 0 milligray to 100 milligray. So what are the strategies to optimize radiation dose in pregnancy? Well, the most important one is that we should only use CT in pregnant patients when there is an appropriate indication. And when there isn't an appropriate indication, we should not use it. When there is an appropriate indication, it's important to optimize radiation dose just as we will do in a non-pregnant patient. For example, we should be using automatic exposure control technique to adapt tube current based on patient size, right, and indication as well. When appropriate, certainly in smaller patients, certainly in patients who are undergoing CT angiography or evaluation of hypervascular lesions, we should, if possible, use lower kVp. And typically patients who are average or less than average in size, we can get away with use of lower kV. The other thing is that if we are doing a body CT, we should be using wider beam because that's more dose efficient. Scan volume should be restricted whenever possible. We should avoid multi-phase, multi-pass examinations. And lead shield, we will discuss this later on in our talk, can be used to decrease anxiety. Although it's not very clear as to whether that helps reduce the dose, but it certainly you have been using it in your practice, you can continue to use them. The other thing that has been reported in literature is use of oral contrast for doing an internal shielding, specifically when you are doing a chest CT, because it acts as a barrier between the chest and the abdomen and decreases the internal scatter of radiation dose to the fetus when we are doing a chest CT. So some of the common indications for performing CT in pregnancy would be pulmonary embolism, renal colic or renal calculus, and appendicitis. This is our protocol that we use at Mass General Hospital and has also been reported in the radiographics article by Patel et al. At 2007. So when there is a patient with suspected pulmonary embolism, we would first do a Doppler ultrasound of both the extremities as is shown in this figure. If we see a thrombus, we would stop because patient has been diagnosed with deep vein thrombosis and the patient's anticoagulation can be started. However, if the Doppler ultrasound is negative, then only we will do the chest CT, and generally as a rule, we will not include the pelvis and the lower limbs as part of evaluation of pulmonary embolism because we have already excluded the deep vein thrombosis with Doppler ultrasound. And if that's positive, again, the patient will receive anticoagulation. If that's negative, the pulmonary embolism is excluded. So, as we spoke earlier about internal shielding, this paper from Yousafzadeh in Radiology in 2006 actually illustrates an interesting aspect of reducing dose in pregnancy. These authors actually used a pregnant phantom in which they actually simulated pregnancy in the phantom. And basically what they said was that if we use barium sulfate up to 30%, now remember in CT we typically have much more dilute barium sulfate solution or suspension, which is about 1 to 2%. So this is considerably thicker or denser than the regular barium that we use for CT. Well, if we do that and if we give and put this into the stomach, it can actually block the internal scattering of radiation dose from chest from reaching the fetus in the abdomen and can cut the dose from internal scattering by about 90%, which is the same as putting a 1 millimeter lead shield between the chest and abdomen. Now, it's important to note that this will only happen if we do not go too much into the abdomen while we are doing a chest CT for pulmonary embolism evaluation, because this is from scattered radiation. So what are the other things that we can do in these patients who are pregnant and have been requested to undergo a pulmonary embolism CT? Well, importantly, we need to center the patient correctly when acquiring the CT localizers, because appropriately acquired CT localizers help to appropriately apply automatic exposure control technique. For the actual transverse images, we need to make sure that we give appropriate breathing instructions as to when to stop breathing during CT examination. And the other thing that's very, very important in these patients is that quite a few of these patients, and different studies report different statistics, but about 1/3 of these patients actually end up getting suboptimal contrast enhancement. So it's extremely important to instruct patients to hold their breath appropriately and also to use a very good bolus tracking or timing bolus or test bolus technique to figure out when the scan should be triggered. The other important thing, as we learned just recently, is the scan length. Well, when we are doing pulmonary embolism protocol as against a chest CT, we should stop at about the xiphoid process, or about, I would say, midway to the dome of the diaphragm. And it's extremely important that we do not go further down in the abdomen, certainly in late pregnancy, so that the direct exposure to the fetus or the embryo can be minimized. And of course, we should not combine the CTA of pelvis and lower limb extremities with the CT of the chest for pulmonary embolism. When appropriate, we should use 80 to 100 kV in pregnant patients, certainly for those who have a BMI of less than 30. Now, the breasts do enlarge in pregnant patients, and that can increase the chest thickness. So therefore, it's important that we take that into account, and some of the newer automatic KV selection techniques will help to basically decide what should be the appropriate KV, but when possible, we should try to do it at 80 to 100 kV, because that would reduce the dose by anywhere from 30 to 70%. And as we learned before, we should prefer the automatic exposure control technique or automatic tube current modulation technique over fixed MA, so that the dose adjustment to the patient's size can happen. Iterative reconstructions can help to reduce the dose by about 30 to 50%. And the use of lead shielding to avoid external scatter is somewhat controversial, since with CT the collimation actually helps us minimize the external scatter anyway. And most of the scatter radiation dose that happen with CT actually happen because of internal scatter, and the lead shielding that's put on the patient's abdomen doesn't really help that much. It does help in a way that if you have a protocol, or if your technologists are prone for a mistake and they will actually go into the abdomen when they are doing a CT pulmonary embolism protocol, the exposure to the fetus will be reduced. So automatically it will actually help the technologist to limit the scan length to the chest only and not go so much into the abdomen. And again, I think the oral contrast agent for internal shielding will actually give you much better results than the lead shielding that's actually done over the surface of the patient. Now, this is an example from our institution where we actually administered patient barium sulfate suspension. You can see the very dense barium in the stomach helps us to basically go too much low into the abdomen. Even if we went too low in the abdomen, you will see that the image quality is virtually non-diagnostic because of the streak artifacts that happen because of this very thick barium sulfate solution. And that actually will, after the technologists have seen this in a few patients, will actually force the technologists not to go too much into the abdomen when they are doing this protocol. There are a couple of things that are very important. Now, first you have to prepare this barium from the fluoroscopy room, because as you know, the barium sulfate that we have from CT is about 1 to 2%, and that's not going to block much of the radiation dose that happens from internal scattering. And the other important thing is that after the patient has had a 1 glass or 2 glasses of barium sulfate, they need to drink some water so that they can actually clean out the barium sulfate that may get stuck to the wall of the esophagus and cause streak artifacts in the chest. So extremely important that you make patient drink some water once they have had this barium sulfate solution. And the other thing that's important is that remember, this is a CT that is being done in patients who are relatively sick and they are prone to emesis and vomiting. So one has to be somewhat considerate to that and make the patients drink this very slowly just before they have their CT. Kidney stone is another indication which commonly comes up in pregnant patients, and CT is the imaging modality of choice because ultrasound and radiographs are somewhat limited due to the pregnant uterus. Well, depending on what period of gestation the fetus gets exposed, whether it's in the early first trimester or the late, the radiation dose does vary, and it can vary from 4 to 12 milligray. Now remember, this is the dose that was recently reported at 140 kV. Most of the abdominal CTs in pregnant and non-pregnant patients should be done at 120 kV, which would cut down that dose by about 35 to 40% and will lead to similar reduction in dose for the fetus as well. For kidney stone, again, as in pulmonary embolism protocol, appropriate patient centering is extremely important so that the automatic exposure control technique, which you should prefer over the fixed MA, can work. Well, so if you have a GE scanner, you can actually use a noise index of 25 to 30, ax slice thickness of 5 millimeter with 120 kV, and if you are a Siemens user, you can use 100 reference MAS, and that should result in a significant radiation dose reduction compared to a fixed MA technique. Now it's important to know that if you have iterative reconstruction techniques, they will help cut down the noise, so therefore you can drop the radiation dose by changing this technique appropriately to achieve a corresponding level of dose reduction with iterative reconstruction techniques. The other important part is that we should limit the scan coverage. So typically for kidney stone, we don't go all the way up above the dome of the diaphragm like we do for routine abdomen. We would start from top of the kidneys and then go to the pubic symphysis. And again, 120 kV or less is generally sufficient to detect a kidney stone. This is a very advanced pregnancy, about 35 weeks, and you can see the hydroureter here, and also you can see a very small, about 3 millimeter calculus at the vesico-ureteral junction. And again, because this is a body CT done over a longer scan length, one should use a wider beam collimation for greater dose efficiency. And as I said before, when appropriate and available, you should apply iterative reconstruction techniques because they can enable 30 to 50% dose reduction approximately. There has been no study, to best of my knowledge, in pregnant patients with iterative reconstruction techniques in kidney stone settings, but I think based on our experience in non-pregnant patients, that's the amount of dose reduction that can generally be achieved with iterative reconstruction techniques. And generally, you would reduce your MAS or tube current to accomplish this dose reduction. So what about appendicitis in pregnancy? Well, typically we would do an ultrasound first. If the compression ultrasound is negative, then only we will proceed with an MR of the abdomen. Now, if the MR is either unavailable or is equivocal or non-diagnostic, that's the place when we will go for CT of the abdomen and pelvis. Now, the availability of MR is kind of difficult in many institutions, so they may actually go for CT abdomen pelvis even before they try an MR. Now, this is a pregnancy at 15 weeks of gestation. You can see the gestation sac here, and you can also see that on this STIR image, you can see that the appendix is actually dilated, filled with fluid, and there is also periappendiceal fluid and edema. You can see that same finding on the T2 weighted images as well. So when we have to do CT of the appendix, we only do it when MR is either unavailable or it's equivocal or non-diagnostic. If we have to do an appendix protocol CT, it's generally a single pass study. And then we restrict the scan coverage from L2 vertebral body, top of the L2 vertebral body, to the pubic symphysis. We generally would use 120 kV, especially important in advanced pregnancies because the patient's girth is going to increase with increasing gestational age. We apply automatic exposure control technique, and that's what I would recommend because that works to adapt the dose according to the patient's size. A non-overlapping pitch, or at least a pitch of 0.9 or higher, should be used. And again, since we are going to be scanning across a wider scan length, we should be using a wider beam collimation because that's more dose efficient when you are scanning over a wider scan length. And again, iterative reconstruction techniques can help significantly reduce the radiation dose and should be used when they are available. So, one of the things that's extremely important is actually a law is that all the radiology waiting areas, including the CT waiting area, should have these notices which should say that to the patients that if you are pregnant, you should notify the technologist that you are pregnant and therefore appropriate actions can be taken, because then the radiologist can communicate with the physician and further confirm if the CT is needed now or is it something elective and can be postponed till the end of the pregnancy. So therefore, it's also important that the technologists in CT and in any X-ray based or radiation based examination ask all and each woman basically of childbearing age if they think that they might be pregnant. And this also helps to take appropriate actions, not just about the appropriateness of CT at that particular time, but also to adjust the scanning technique so that the exposure to the fetus or conceptus can be minimized. We do have an informed consent form that we will use if patient is pregnant and is undergoing any imaging examination, including CT, which will inform them about the risk, inform them about the dose, and in addition, we will actually convey this to the physician that patient is pregnant, or even at least confirm with the physician that the patient is pregnant and an imaging test is required at that time and cannot be postponed till the end of the pregnancy. So in summary, pregnant women must be advised that X-ray radiation from one diagnostic procedure does not result in non-cancer adverse or harmful effects to the fetus. And generally speaking, a radiation exposure of less than 100 to 200 milligray. And remember, the CT exposure is generally in the double digits, much lower than this exposure, is not associated with any measurable increase in non-cancer fetal risks. And most radiology investigations, whether it's CT or X-ray or fluoroscopy, are actually associated with less than 100 milligray. Thank you.